All righty. I think we're going to go ahead and get started. As is our tradition, we start at 12:15 precisely. And thank you all for coming, and I'm sure more will be streaming in as we go along. But as you know, this is our clinical conversations for the month of June. So hello and welcome to everyone. As always, they're taking place on the fourth Tuesday of the month, and we always take a break over the summer so people can hopefully have better plans in July and August for this hour. We will reconvene for the next session in September on September 24th, so mark your calendars. Today's topic for the clinical conversations is the evaluation and management of suicide risk in the pediatric primary care setting. And I'll talk a little bit more about our speaker, but before I do, just to remind or just to let people know some housekeeping. As you can see on the screen, if you're on a computer, you can get your CME credit through our friends at Massachusetts General Hospital. And the CME code that has to be texted in is ZEVYUT. So as usual, we're going to record this, and so you can tell your friends to check it out if you like it, and the slides will be available as well on the website. So the MCPAP.com website under Toolkits and Resources. This is a clinical conversation, so we would love for there to be interaction. And so if you have a question, just put it in the chat or ask in the chat to be unmuted, and we'll either read your question or you can ask it yourself, and we may save some questions for the end, or if it's really relevant to what our speaker is talking about at the time, I will gently interrupt him. Dr. Bromberg, you don't need to worry about keeping an eye on the chat unless you want to, but we'll be glad to monitor that for you. If you have a moment at the end, we would really appreciate if you could just fill out the brief survey just so that we can get some feedback and make sure that we're shaping this program to meet your needs. Okay, so now for our session and our introduction. Our speaker today is a really wonderful and accomplished person. His name is Dr. Jonas Bromberg. Dr. Bromberg is a clinical health psychologist who has been working at the intersection of behavioral health and primary care for his career. And he's been a really great friend to MCPAP. His work is focused on improving access to care, which is, of course, the central mission of MCPAP for kids and families. Also helping specialists and organizations design and implement different clinical models for connecting, primary care and healthcare services with mental health treatment and mental health expertise. He used to work at Children's at PPOC. He was the leader for their innovative BHIP program, which has been nationally recognized and has really created a really wonderful clinical integration model, kind of joining 125 behavioral health clinicians with primary care practices across Massachusetts. Dr. Bromberg is currently practicing clinical psychology and is working in Wellesley, Massachusetts in private practice and doing consulting work to try to help other organizations to implement different models for primary care integration. And his consulting company is the Crossroads Health Consulting. And it's really his space really is around helping organizations to integrate behavioral health, primary care, and specialty medicine. So with that, I'm going to turn it over to Dr. Bromberg. Thank you so much, Jonas, for being with us, and we're really excited to hear your presentation.
Thank you, Barry. It's great to be here today talking to you all and continuing to have this relationship with MCPAP, which was so instrumental in the work that we did at the PPOC. I don't see my slides.
Parvina, are you going to put up?
Yep, it's
oh, great.
sorry,
Awesome.
it's coming up now. Sorry about that. Give me one. Click the right one. Okay. Okay. Still not the right one. Okay, let me know if you guys can see that now.
No.
Yeah, no, we actually, I don't.
Oh,
Teams has not been.
yeah, it shows that I'm sharing. Let me try it again.
Teams is not our friend today.
How about now?
Yes.
Yep.
Yay, we did it.
All right. Next slide, please. Okay, I have no disclosures. We can just move on. Just a tiny bit of background about me, as Barry mentioned. A really important area of the work that I did over the last decade was supporting primary care teams and managing suicide assessment in their offices, and implementing EHR documentation to support that as well. And the thing that I'm really proud of is that our team at the PPOC, for the last decade, we managed to keep the number of ED visits for a primary behavioral health concern flat, while that was increasing statewide and nationally. And I think a large part of that was due to the emphasis and focus that we placed on helping, care teams manage this sort of thing locally, and being able to do that work without reflexively sending kids to the emergency department. Next slide, please. So I'm going to review very briefly some things that were covered last month by Dr. Dickstein. And I'm going to go through that very quickly. It may sound like speed talking, but then it'll get us to this point where we're going to talk about risk assessment, safety planning, and follow-up, which is really the meat of what we're going to talk about today. Next, please. So Dr. Dickstein shared last month the suicide algorithm, and this is available on the MCPAP site. And if you can make one click, Parvina. That's going to highlight the section of this that we're going to really delve into today. Beyond the screening, we're going to delve into sort of the risk assessment and safety planning and follow-up. So next, please. So next, please. Just, a few quick facts, which, all of you, I think, understand and know well, that, many youth who die by suicide or make a suicide attempt have had a visit with a healthcare provider in the previous year. And so that really, again, is the emphasis of why this is so important and why we're, MCPAP is bringing you this content today and last month. So next slide. Suicide can be a really challenging thing to talk about with your patients. It can lead to fear, anxiety, and stress, and can lead us as clinicians to either overreact or underreact. I think the chief thing I want to convey here is related to this top bullet. When we ask about our patients about suicide, we are not going to give them that idea. I mean, that is a myth, and I want to debunk it. All these other things can come up, and this bottom one about not being able to handle this here. I really hope that between last month's talk and today that we can all give you a feeling that this is something that you are capable of doing if you're prepared and know how to do that. Next slide, please. So suicide's a very intense subject, and I want to encourage you all to take some time to think about and understand your thoughts, emotions, beliefs, and experience related to this topic, because they can greatly influence your response to how you handle this in the moment with a patient, whether you've known somebody that's committed suicide or have, beliefs and, about suicide or your own emotional reaction to it. I think it's well worth taking some time and probably taking time as a team, a care team, to talk about these things as a one important step in the process of helping you prepare to deal with this very intense subject with patients. Next, please. In its most simple form, what we're going to talk about today in terms of assessing risk really involves weighing the balance between risk factors and protective factors. And we're going to get into a lot more detail about what this means as we proceed. But this is simply what it's about. Next. Just to discuss very briefly some common risk factors, which I think you all are pretty familiar with. Certainly previous suicide ideation or attempt and feelings of hopelessness and helplessness are really common risk factors that we want to pay attention to at the individual level. Next slide. At the social relational level, we know that youth exposed to adverse childhood events, those that are lacking in social support, experience social isolation or bullying, those involved in families or where there's a lot of conflict, or with peer groups where there's conflict, are also those are significant risk factors. And family history of suicide, a very important risk factor. Next, please. At environmental and community level, here are some examples of risk factors. Access to lethal means is something we're going to talk a little bit about later on. Certainly the stigma of asking for help is an important thing that we want to think about here. And, you know, we've all heard and seen in the media graphic and sensationalized accounts about suicide, particularly what's called cluster suicides, or, you know, the suicide contagion, where numbers of people in a maybe given community commit suicide. These tend to get a lot of attention and can be a significant risk factor for many youth. Next, please. On the other side of that is the protective factors, those things that help build resilience and help dissuade youth who are contemplating suicide from following through with that. And certainly, you know, these largely mirror the same domains of social support and connectedness and relationships with trusted adults and others who can be helpful. Support from healthcare providers is important. And these are, again, things that can help prevent suicide in individuals. Next slide, please. They're often referred to as warning signs. These are things that happen, the experience of patients, either behaviors or things that we observe that put them at greater risk. And I'm not going to read through every one of these. These are familiar to most of you, if not all of you. Next, please. And this is what warning sounds sound like. These are the things that we should be paying attention to and listening for as we talk with our patients. Certainly feelings of wishing they were dead or they can't go on anymore. People would be better off without me. Those are sort of common sort of warning signs and signals that we should be particularly attuned to. Next. And a warning sign does not mean that a person is automatically going to attempt suicide, but it's a signal to us that we should respond to this situation in a serious and careful manner, and not just simply dismiss it as a cry for attention or something like that. We really want to take these warning signs very seriously. Next. So we're going to touch on a little bit about screening, which I know we covered last month, but important to review some of that here. I think not everybody that may be with us today attended last month, so quickly we'll go through this. Next. Why do we screen patients? Because we know that they don't tell us everything that they're thinking. We learned last month, and you all probably know as well, there are a number of ways to do this. There are a lot of different recommendations about who to screen and how to do it. Sometimes those can seem or feel conflicting, so it gets complicated. Next. You're probably familiar with the American Academy of Pediatrics recommendations for screening. There's a link to the website here. I would encourage you, if you aren't familiar with this material, to access that and look at this in more detail. Next. The U.S. Preventive Services Task Force has some recommendations too, and something I think contributes to some of our confusion about this, about how to do it and where to begin, is that they conclude that the evidence is insufficient on the benefit and harms of screening for suicide in children and adolescents, and that the balance of that, so it cannot be determined whether screening is a useful thing or not. So I think that leaves many of us feeling like, wait a sec, this is a government, prominent government task force. How can they, leave us in this way? So next slide, please. So where do we begin? What you see here are some thoughts and ideas that I've heard from pediatric providers, and they're really all over the sort of map here. I think the idea of beginning universal screening at age 13, at least in our state in Massachusetts, corresponds with that age of adolescent confidentiality. And, that's a spot that many people choose to begin this. We're going to talk about depression screening in the mix here in a little bit, and all sorts of ideas about when to do this, when I think there's a concern, when I think I should do this. Really not a very pragmatic or systematic way to do this. So let's go to the next slide. So where do we start? And I think Dr. Dickstein, talked about this last month. We want to start where it's feasible. We're all very busy in primary care, attending to a lot of different things. And so what's feasible? Consider what's feasible given the population that you care for and your clinical staffing. How can you make best use of the limited resources that you have? And as Dr. Dickstein talked about last month, it may be extremely difficult to influence the outcome when a patient's thinking about suicide because of the nature of it as an impulsive and unpredictable sort of act. But we want to really begin where it's pragmatic, and then if and when it's feasible, move toward a more universal approach. One of the things that we considered as we were talking about this in the network I worked in was, if we do it universally, are we going to just be crushed by the number of people that need follow-up and further assessment? And so we chose not to do it universally. So consider sort of a phased approach and what's really pragmatic given your resources. Start with some specific populations or indicators. Next slide, please. And one way to start is to base your approach on the AAP recommendations, either starting with patients that have a history or symptoms of suicidal ideation. The patient demonstrates some warning signs or communicates in some way that they're contemplating suicide. Patient or parent reports some concern, or thinking about segmenting this in terms of patients with behavioral health concerns, with depression, anxiety, substance use are often good populations to consider starting with. Next. We talked, as you heard last month, there are two sort of directions people go with this, using validated depression screening and suicide-specific screening tools. And there was some discussion of all this last month, so we can go on to the next slide. As you know, and probably very familiar with, this 9th item on the PHQ-9, very direct question about suicide. Next slide. Mood and feelings questionnaire has a set of questions addressing this. Hopefully you're all familiar with that as well. Next slide. So is depression screening a good approach? And the answer is no. We know that even, that we miss a significant number of patients if we just rely on depression screening. And even when we look at just question 9 of the PHQ-9, that suicide question, we tend to miss even more. So it's a little counterintuitive, but that is what we know. Next. So why do we want to screen specifically for suicide? We know it's the second leading cause of death in youth ages 10 to 24. I believe it's our job as primary care providers to know mental health is health. Knowing leads us, asking about it and knowing is the only way we can confirm the risk. It leads us down the pathway to intervention. It informs the next steps that we take. And so this is why we want to start by using a suicide-specific screening measure. Next. And the best way to begin is to be prepared. I would encourage all of you to have some sort of rehearsed way, a script to kind of introduce screening to your patients, quick and easy, consistent. I would encourage you to develop this using your own words and style, and develop it as a team. Consider developing a way of introducing this and a protocol for doing this that's used consistently by everybody in your office, so that they're all doing it largely the same way in a reliable manner. It's best to have the patient complete screening privately. We know that for many types of health risk behavior, when patients are given the answer to respond privately, they are more honest. But if you don't have the opportunity to do that, if you ask the patient directly as an interview, whatever tool you use, be sure to follow the exact wording. These are validated tools, and using exact wording is important. Next. So this is the ASQ, which we saw last month, the 4 introductory questions. And on the next slide, we'll see that 5th question about the presence of, suicidal thoughts right now. Next. And it's really, what we do next really depends on that 5th question and the level of acuity. If the answer is yes to any of those first 4 questions and yes to that 5th question, which is rare, we want to proceed to a full suicide evaluation and really implement full safety precautions. If it's a less acute situation, yes to any of the first 4 questions, but a clear no, that the patient has no present thoughts of suicide, we can proceed to a brief safety evaluation without needing to do full safety precautions, but we should be prepared to build a safety plan with the patient, make sure that they know how to access the helpline numbers, and in certain cases, discuss the restriction of lethal means and the safe storage of medication. Next, please. Again, initial response really matters. It's important to ask about this. It's important to ask about it directly. So one more click, please. Please use the word suicide. Patients will get a sense that we're apprehensive or, beating around the bush if we don't use the word suicide. It's going to put them at ease if we're direct and comfortable using that word with them. So please ask about suicide and use the word. Next. The initial response matters, and letting the patient know that you heard them, thanking them for telling you, letting them know that this must have been a difficult thing to share, and doing so in a calm, matter-of-fact way, being aware of your facial expressions and tone of voice. And the most important thing that we want to do at this step is really to convey hope and support. One click, please. And to not, make sure the patient knows that they're not alone, that we're there with them, and they're going to be there for them to guide them through this really difficult moment or set of feelings and thoughts. Next, please. And at this point, the focus of your visit really shifts from screening to risk assessment, digging in deeper. And again, I think, having a script, a way of introducing this, ready to go at hand, that you've practiced, that you feel comfortable with in your own words, is really important to make this shift into this element of the visit. Next, please. So I know the folks at MCPAP, along with I, want to really use this talk as a way to convey to you that you can do this. This is really doable in primary care if you're prepared and have the right tools. And that's what we're here to do today, and what we wanted to accomplish last month. Not everyone needs a higher level of care to determine risk. And there really is no magic in the emergency department. A visit to the emergency department is typically a very traumatic experience to patients and families. As you must know, it ends up being not very useful in many cases. And for those of us, which I probably is all of us, that are interested in helping manage cost, it is often a very expensive procedure that, which there's very little gain from. So being able to do this locally in your primary care office, or if you don't feel prepared to do that, using a local emergency service team, much better way to approach this than the emergency department. Next, please. So we're going to delve into risk assessment next. And, simply, risk assessment is different from screening. Screening identifies that risk exists, and the risk assessment takes us down a pathway of considering how much risk exists, the degree to which there's an actionable risk is present. And this question that we all want to know, is it safe to send the patient home, or do we need some other next step, immediate intervention before we can safely send the patient on? This can be completed briefly and, sometimes in as quickly as 10 to 15 minutes. Many EHR systems are built to support this, and it should be something that your clinical care team talks about, plans, and builds a sort of workflow and process so that when these events do occur, that everybody knows how to do it in a simple and easy way. Next slide, please. So again, we want to be able to determine the level of risk when a child screens positive. We want to begin by explaining to the patient or parent why we're doing this. And we want to use, as much as we can, the patient's own language in doing this. It's going to really help the patient feel heard and understood if we use their own language. And we want to frame our questions in an open-ended way. We don't want to ask questions where we just simply end up with a yes or no answer. We want to use our questions as intervention to elicit as much information as possible throughout this type of assessment. One thing we want to observe is whether the patient's behavior and what they're reporting right now in the moment is consistent with information that you may have obtained previously, or from the patient or from other sources. And to keep in mind that this step of assessment is really the beginning of your intervention. And again, I think conveying this in the patient's own language is really going to help them feel heard and understood in an important way. So next. Here's some examples of open-ended questions that cover some of the same domains, thoughts and behaviors, availability of support, who's there for them, who can they count on. Begins to get into some of the things that are either protective factors or elements of resiliency. The things that they've done, have experience with, that help keep them alive, help keep them optimistic, and the things that they rely on to keep them safe. So these are examples of those types of open-ended questions. Next, please. I'm including this again because I think it's really important to use as much of the patient's language as possible, to really listen to how they talk about it, and to really attend to how they talk about what they need. Again, I think this goes a long way to helping the patient feel heard and understood, and that you're taking this seriously and really listening, hearing them and are there for them. Next, please. So the primary domains that we're going to assess fall into these three areas: thoughts and behaviors, symptoms and their context, the patient's context, and the availability of support. Next slide, please. In terms of thoughts and behaviors, the things that we really want to assess here are the same sorts of things we want to assess with any sort of mental health concern: the frequency, the intensity, and duration of that concern. What the specific thoughts are. Have they had it now? Have they had it in the past? When's it been at its worst? How long has it? How long do these thoughts last? Those sorts of things. And then we want to delve a little deeper into whether the patient has a plan. Have they thought about how they would kill themselves? The timing, the location, the means that they're going to use to act on their thought, the lethality of those means and the availability of those means, and most importantly, have they taken any steps to prepare? Obviously, correlating with much greater risk if a patient has gone to prepare to kill themselves. Next, please. We obviously want to know about past history, both past attempts, and ask specifically about aborted attempts or rehearsals, things that have gone beyond just simple thoughts. And it's surprising, I think, to many of us, how often past attempts or aborted attempts are not known by other people, that they've never told anybody. So we want to make sure that we ask them, did anybody know about this previously? We also want to ask about non-suicidal self-injury, cutting, burning, mutilation, anything like that. That's not necessarily going to be lethal, but harmful to the individual. And in some cases where it's indicated, we want to also inquire if we suspect there's some disordered or thought thinking problems going on. We want to ask very specifically in some cases about whether patients are hearing voices or getting instructions to sort of harm themselves. Next, please. The next thing we want to do is think about intent, the extent to which the patient expects to carry out the plan, and believe that the plan is going to be potentially lethal versus just simply harmful. What are their thoughts about that? And what are the things that have put them at risk? What are the reasons that they want to die? What are the reasons that they want to live? So we want to inquire about both those things. Again, that decisional balance of risk and protective factors. And we want to pay attention to, again, their language, how they describe the potential outcome, the reasons for wanting to live, reasons for wanting to die. Those all go into that calculus of that decisional balance that we're trying to achieve here. So pay really close attention to the language. Obviously, when a patient says something like, I don't want to die, but I don't want to suffer any longer, that clearly indicates some lower risk than somebody that says, I'm dead, it's over, with some higher degree of certainty. So really think about how they describe the outcome of what they're contemplating. Next. These should be very familiar to you all, the symptoms that are commonly associated with people who are contemplating suicide. One more click, please. And I just want to pause and ask people to put into the chat, are there other in your experience, are there other symptoms, other things that you consider along these lines other than the things that you see here? And I'll just pause for a moment and somebody can let me know if other ideas pop up in the chat. Okay, this is probably covers most of the things that we would all typically think about. So next slide, please. The next domain that we want to assess is, again, the level of social support and stressors that may be present in a patient's life. We want to definitely be aware of and know about their family situation. Is that particularly stressful, or is it supportive? For children who obviously spend a lot of time in school, their current school functioning, and whether that may be a source of stress and problems, we want to note that. Socially, whether children are exposed to bullying or teasing or other sorts of abuse. And again, things that allude to these risk and protective factors, and whether they've shared these thoughts with anybody in their social network. Next, please.
Hey, Dr. Bromberg, someone in the chat was wondering if you could say a little bit more about assessing sleep in relation to suicide risk.
Yeah, I mean, the thing that comes to my mind is, kids that are sleeping excessively, having difficulty getting themselves out of the bed in the morning, maybe sleeping, throughout most of the day on the weekends, or even sleeping through the day, on weekdays, just can't get up to get to school. So it's that sort of level of, where sleep is really interfering with them being able to, execute their daily functioning. And I guess in some way, I would also consider kids that are having trouble falling asleep, that may have, might want to inquire about, what they're thinking, while they're having difficulty falling asleep. Are there preoccupations with things that may lead us down this pathway of concern about suicide? I don't know, Barry, if you have any thoughts about that as well, or if that sort of covers the question in a reasonable way.
No, I think I think that's a good answer for me. I don't think I could even add to that.
Okay. As you already may know, and as we heard about last month, the ASQ, not only is that a screening tool, but it provides a really robust assessment framework that largely covers the areas that I just described. So I would really encourage you all to make use of this. This is both the screening tool and the assessment framework that MCPAP feels is probably the best one and easiest one, most thorough one for you all to be using in primary care. Next slide, please. So we've gone through this assessment. We've determined the risk level, as you can see on this table here. Each level of risk is associated with some level of intervention. I'm not going to spend a lot of time here. You can look at this afterward on your own, but generally that level of risk is going to guide what you do next, from making referrals, or whether some immediate intervention to secure the patient in a safer environment is needed in the event of a high level of risk. Next, please. So after we've gone through this assessment, measured that decisional sort of balance, we want to delve into the next step of our intervention, which is safety planning. Next. And a safety plan is a very individualized, personalized document. It's a document that we create. Ideally, it's created with the patient, along with some clinical care provider who's knowledgeable about the goals and elements of creating that type of plan. And the plan helps outline the very specific actions that the patient's going to use if they're feeling unsafe, and with a special emphasis on actions that the patient has used successfully in the past. And again, this is a way to really convey support and hope to the patient. If we incorporate into this the patient's own knowledge of being an expert of their own experience of knowing and understanding and utilizing what helps them best. The safety plan is going to help the patient when they're in distress, and utilizing things that they've had success with in the past is going to empower them, and I think help them feel as safe as possible. And we know that when we create good safety plans and patients use them, that they do reduce suicidal deaths. Next, please. So again, the safety planning is an important step of the intervention. It leaves the patient with kind of a game plan. And I think leaving your office with a safety plan can feel really assuring to a patient, and probably to the parent as well, maybe more so to the parent. And the safety plan is really designed to be a quick and easy tool for the patient to look at, reference, when they're, feeling like an impending crisis is coming on, when they're starting to have suicidal thoughts. Helps them know which direction to turn for help and support. And again, it relies on things that have helped them in the past manage these sort of difficult things. We want to be sure to ask the patient and parent to keep the plan in a place that's easily accessible, where everybody knows where it is, knows how to access it when it's needed. Next, please. The right-hand side of this is not an eye test, but it's a general template for the safety plan that has these elements that you see on the left. So we're going to talk with the patient. We're going to help them document and list the kind of personal warning signs, the thoughts and situations, behaviors that'll alert them that they're maybe headed toward a crisis, and to do this in the patient's own words. We're going to incorporate the patient's individual coping strategies, again, with emphasis on the things that they feel that they can do successfully and have used in the past. We may supplement that with some suggestions that we have about useful coping strategies. Importantly, knowing who to contact, family members, friends that they can count on to be helpful, knowing how to access the established helplines, uh, crisis teams, things like that. And then the things that we need to do, that the patient needs to do to help assure that the environment is safe, and when necessary, limiting access to the applicable means of suicide. Next, please. And the simplest way to increase the likelihood that the plan is going to be utilized is ask the patient these sorts of questions. Where are you going to keep the plan? How likely do you think it is that you're going to use the plan? What might get in the way of you using the plan? And what can we do to remove those barriers if they say there's things that are going to get in the way? So helping the patient prepare, think through the process of, where this is, how am I going to use it, when the need arises, is going to really increase the likelihood that the plan is going to be used and helpful to the patient and family. Next, please. Again, not an eye test, but this is something you can look at closer on your own time. But really, when we move to help families restrict lethal means, we know that this dramatically decreases completed suicides. Next. And we're going to talk about two particular areas of lethal means that we want to attend to. There are other lethal means other than guns and medication, but these are ones that we're going to emphasize here today. And when we talk with patients and families about this, we want to emphasize that this is a standard practice. This is not, just for them, that this is a temporary necessity to keep them safe. And again, we want to approach this in a matter of fact, calm sort of way, both with guns and medication. We want to ask about the presence of guns in the home, about whether they're locked in storage, whether families use gun safes or trigger locks. Ask about whether guns, if they have them, can temporarily be removed from the home. And inquire about whether there's access to guns in the homes of family members and friends. And much in the same way, we want to ask about medication, what types of medication exist, what kinds, and whether parents have considered or use medication lockboxes. And again, whether medications may be available in the homes of family members and friends, and whether parents may want to, inform people that the patient may be spending significant time with, about, the need to restrict access to these sorts of things temporarily during a period of time when the patient may be unsafe. Next, please. So, as you know, youth are often private about many thoughts, including thoughts of suicide, and it's not uncommon for parents to be unaware that a child is either thinking about or, taking some action toward suicide. So we really want to make sure that when we ask parents about this, that we do that in a non-blaming, non-judgmental way. This is a routine thing that, we want to convey as much of that routineness and calm as we can in this type of situation. And here's an example of sort of how to frame that to a parent. And again, I'm concerned. Your child has shared some thoughts with me. Has he shared these thoughts with you? Next slide, please. Another important thing we want to make sure that we do as part of the safety planning is make sure that patients and families know about, have access to these numbers, which I'm sure you all know well. In Massachusetts, our behavioral health helpline and the National Suicide Helpline. In many cases, we want to make sure that the patient and parent save these numbers, put them on their phone while they're in the office. You may want to practice with them what they're going to say when they call. And in some rare cases, you may even want to have the patient or parent use the helpline during a visit. So again, an important part of safety planning, making sure the families are educated and aware of these helpline resources. Next, please. I'm going to talk a little bit now about, we've gone through this assessment, we've determined risk, created a safety plan around that. What do we document? Next slide. So it's going to fall into sort of four primary domains. The first having to do with the level of risk and what we've observed as the evidence supporting our determination of risk. So many of you may be working in EHRs where you can create some sort of smart phrase or templated response that you can customize in each individual instance. But, include in your note the level of risk and, again, that evidence that you've obtained supporting your determination of risk. Next. Whether you've consulted with anybody or not would be an important thing to document as well, whether you've talked to an outpatient therapist or psychiatrist, somebody else that may have knowledge of the patient and their thinking about suicide or their assessment of the intent or the family environment's ability to support the patient. If you've done this, include this in your note. Next. The next thing you want to document is what you did to address or reduce the current risk. Did you schedule a follow-up? Are you planning to or have made a mental health referral? Have you developed a safety plan? Reviewed with the patient and family the crisis helpline numbers. Again, some of this can be templated in an EHR that allows you to do that so that it can be customized for each individual instance where you may need to use this. Next. And then finally, what are your next steps? What are you going to do? What's the patient and family going to do to ensure the patient's safety? Make sure you document that in a clear way so that everybody on the care team and the patient and family, if they're going to access your note through a portal, they may want to refer back to this and make sure they're clear on what the next steps are that they should be doing. Next. So we've assessed risk, we've created a safety plan, we've documented it. And the next important thing that we want to do is follow up and monitor these patients. Many of the offices that we worked with developed a follow-up protocol for this and other sort of high-risk things. And many offices that I worked with developed what they call a high-risk registry, both patients who are demonstrating suicidal thinking and behavior, but also sometimes including on this patients that have had hospitalizations or other intensive outpatient services. Creating this registry, which would get reviewed frequently, if it's feasible, ideally weekly. And then as a care team, think about how you're going to follow up with these suicidal patients. Who's going to do that? Is it going to be the PCP? If you're in an environment where you have an integrated behavioral health clinician, is that somebody that could be involved in the follow-up? Determine what sort of level of, what frequency you're going to follow up with, how you're going to involve the parents in that follow-up. Outline, in your protocol, what types of external referrals should you make? And then on your end, who's going to coordinate that? Who's going to coordinate those referrals and communicate with external providers, not only at the point of referral, but in an ongoing way for patients that remain at risk. We want to keep an eye on them and monitor them till we're assured that they're in a better, safe sort of state. Next. So the key takeaways here are, absolutely don't hesitate to inquire about suicidal thoughts and behavior. Be very direct. Use the word suicide. And as an individual practitioner and as a care team, do work to increase your comfort and preparedness to screen for and ask about suicide. Know how to create a safety plan, know how to contact local emergency service teams, and have a management plan in your office, for how to do this sort of thing. Again, these things are going to go a long way to help you as an individual and as a care team be prepared to do this. You can do this. And, don't let these patients go. Follow up with them, make sure that they're monitored in a robust way, as much as you can. Next. Quickly, a few resources. I know Dr. Dickstein shared this with you last month. On the NIMH website is not only is the ASQ screening tool there, but this very robust toolkit to help you manage these sorts of things. Hugely valuable resource. Next. The Zero Suicide Organization also has a toolkit, many of the same types of tools, also worth taking a look at. There's 2 links here to refer to. Next. This is a great resource for parents and caregivers. May also be very useful to clinicians as well. Suicideisdifferent.org is the organization. They have some very good material here. Again, much of it may be written more at a parent, good resource for parents and caregivers. Next. And this is kind of a cool app, the Not Okay app, which is a way for patients to alert a trusted contact. One more click, please. So basically, this app takes you through a process of the patient, sending out an alert to their trusted contacts, the contacts being able to acknowledge that, make contact with the patient. The app also provides some really basic, simple ways to reduce the immediate sort of stress or discomfort. And then it provides a way for the patient to send an I'm okay notification out to their contacts when they're in a better place. So could be a very useful app in some situations. Next, please. These are some other resources. Not going to spend a lot of time on these. These should be familiar to you. And they're next slide. This top resource here, this is the form. This is a safety plan template form that was in a little image in the previous slide that we saw earlier. And again, some other resources to consider. Next. So I'm going to pause here, open for some questions. And if anybody, it'd be really wonderful if folks could share any experiences they've had, what's been most difficult and what have they found most useful. Sharing with your peers, these sorts of things can be very helpful. And when you encounter these situations, learning from others, especially what folks have found most helpful in managing these sorts of situations.
Hey, Jonas, while we're waiting for some questions in the chat, I thought I would bring up a question for us to start talking about. So there's a population of patients that has chronic, suicidal ideation, and I kind of feel like a lot of people have trouble assessing, the acuity of the suicidal ideation. I think that's the way I would frame it. That sometimes these patients aren't taken seriously because it's not sort of a new thing. And at the same time, I think people often sort of underestimate the risk, or they don't necessarily kind of know how to parse out the risk, in the context of someone who generally always has suicidal ideation, as well as, possibly, sort of chronic self-injurious behavior. Do you have any thoughts about how we should advise people to approach, that particular issue?
Wow, Barry, that's a tough question, and certainly a really difficult and challenging population. It can be very frustrating. So again, I think exploring our personal sort of responses to those patients and not getting lured into this, complacency. If we, when we hear this over and over and over, we can kind of get into a place where we don't take it as seriously and dismiss it. And I think we have to, as difficult as it may be, we have to take it seriously each time. And I don't know, I think I would explore the patient. I think we really want to try to understand and get at if we start with the approach that all behavior is purposeful in some way, like what is this? What's the purpose of this? How's this serving the patient in some kind of way? Those are the things that I think about right away, Barry. I don't know what it's a really difficult question, a really difficult population to care for. So I don't know what other thoughts you have about
Yeah.
that or anybody else.
Well, yeah, let's see if other people have it, because I actually get that question fairly often from primary care clinicians. But I do have a sad anecdote, to share. That there was a patient that we reviewed in an M&M a while ago who was a completed suicide patient. He was a transitional age youth, and it was the situation that he had very, very persistent suicidal ideation and self-injurious behavior, and so we discovered retrospectively, that he had gone to a doctor to ask, because he had a pacemaker, and he had gone to a doctor to ask the doctor, just out of curiosity, whether or not how to turn his pacemaker off, temporarily, and that he had a plan to commit suicide, and he was worried, that his pacemaker would resuscitate him. It was one of those pacemakers that's kind of designed to kick in when it's needed, but isn't continually stimulating. And so we discovered that after. That's clearly a very ominous sign when people start plans, and they start kind of exploring that and asking questions, and that had come up, and it turns out that prompted an extra urgent session from the patient's therapist, but the therapist had explored this with the patient, and the patient convinced the therapist that it was just part of his chronic musings about suicide, and that he had no intention, and that he had plans for the next day and the next week, but he actually, after that therapy appointment, the next day, he had actually taken action. So I think it's it's kind of a tale of caution, to not allow yourself to be complacent, as you say. So there is a question in the chat. It says, what are your thoughts on a youth who threatens to kill himself if his girlfriend leaves him, and the young woman changes her plans to break up? So they're going to stay together for now, but had kind of talked about that as a contingency. Yeah.
Oh golly, these are not easy questions, as one would imagine. That, I guess my first thought is, this is a patient that really needs to be plugged into some pretty significant ongoing psychotherapy support, if they're not already in that. I think if there's some way to, in that sort of situation, to provide some sort of support to the girlfriend, obviously confidentiality is going to be a big issue here, but how do you help support that girlfriend, and probably that girlfriend's parents? Does the parent of the suicidal patient want to have some sort of conversation with the girlfriend's parents? I would, my thoughts are, helping protect that girl in this situation. Wow.
Yeah.
These are, these are hard questions. These are some of the most difficult sorts of situations we face in primary care, right? These are unusual, really difficult. I'm not sure that there's a stock answer, a best answer. These are things where you have to really approach, I think, each individual situation and do the best you can.
It's hard to, we can't necessarily come up with the assessment, without having more data, on these. But it's good to think about how to approach it. So there's another question. I think this is our last one, because we only have a minute left. But How seriously do you take a suicide statement from a younger child, say age 7? Does a 7-year-old even understand what they are saying? What would you say about that, Jonas?
Yeah, absolutely. Take it as seriously if it was being said by a 17-year-old. I think you have to approach it in a developmentally sort of tailored way. The way you'd ask questions and do your inquiry as part of your assessment would be different. Safety planning would be the same. Use language that's appropriate to a 7-year-old. So yes, absolutely, take it just as seriously.
Yeah, I totally agree.
Before we wrap up, we just show one more slide because I just want to, the people here represent a subset of their clinical teams, and I just want to encourage everybody to share the content of this program with the rest of their care team and to really take seriously this idea of thinking as a care team about how to prepare for this, how you're going to transfer this knowledge and share it with your team, because a prepared team is likely going to be a more successful team, and we want to be as successful as we can in as many of these instances as we need to be.
Yes, absolutely. And actually, there is one more question,
Sure.
which is an interesting one. I think it's a really quick one, too, if you know the answer. I actually don't know the answer. But if you do, it's fast. So it says, I recently learned that removal of guns requires someone with a license to carry to accept them. Do you have any suggestion for ways to remove them to help make it easier for families? In a recent situation, law enforcement was not able to accept them. So that's what I thought to recommend, is that you can bring them into the police station or something like that. But do you know the answer to that?
I don't know the right legal answer to that, Barry, but I would, I wouldn't worry about that. If there was imminent risk, I would remove the guns in whatever way I could, and then, try to figure out the best legal way to manage that as possible.
Yeah. These are, people ask really hard questions, but it's really nice that people are asking. And Dr. Bromberg, thank you so much. It was a fantastic presentation. I think it exceeded all the expectations that we have. And thanks everyone for your attention and for participation. And we'll look forward to seeing people back in September. And have a great summer. And thank you again, Dr. Bromberg.
Thank you. Be well, everybody.